dive into it. Complications in veterinary dentistry. There's a lot, and I've selected some, and maybe I didn't get all of them in here, but then we can talk about it after if you have some special things. We're going to talk a little bit about the hissons, so when the wounds they open again. What happens if we put the root in the mandibular canal or nasal cavity? The penetration of the eye. We all hear about, we're afraid that we may slip and stick something into the eye. We will see various degrees of emphysema, talk about how to avoid tracheal tear. I don't know about you, but has anyone experienced tracheal tear in cats? I used to work in emergency too, and I would say at least a couple of times a year there will be a cat that came in with a tracheal tear because after a dental procedure. But we'll talk about that. Also sublingual swellings and pretty rare one, chewing the tongue due to local anesthesia. It should never stop you from doing it because it's extremely rare, and I'll talk about a little bit about that. So after a dental procedure, your patient wakes up and it looks like this. Have anyone seen this before? So you have to think, okay, what happened here? And it can be a good thing or it can be a bad thing. And usually it's not a too bad thing. Usually it's just because of some retropharyngeal swelling. So you have to think about, did I penetrate the globe or did I penetrate the orbit? Did I do some damage on this retrobulbar area? So how can you get swellings in the retrobulbar area? So let's say you do a nerve block and you hit a vessel, or you just extract the last molar. Sometimes you just extract the molar, everything goes smoothly, and when the patient wakes up, it looks like this. It is not extremely rare. It happens sometimes that the eye will start to swell. It's not actually the eye, but it's the periocular tissues, and it swells. And it could be just a reaction from getting a tooth out or injecting something, and usually you just make sure the eye is well lubricated, and it will usually go down after like a couple of hours, one day. It will be back to normal. You could, if in severe cases, you could do like a temporal tarsography, where you put some sutures, close the eyelid a little bit. I've never had to do that. I haven't seen too many of these, but it's usually not a very serious thing. If you suspect that you hit the eye with something with your instrument, then you should look for meiosis. You should look for flare, so have some light. You can look into the anterior chamber of the eye. If you penetrated the globe, it doesn't have to be a death sentence for this eye. It can survive with anti-inflammatory and antibiotic agents and so on. But it's very rare. There was a diplomat once that shared a case where she penetrated the eye, and the eye was lost. They took it out, sent it to histopathology, and they could examine the exact spot where the luxator went in, and they could see it on histological. So good example for a museum, not so good for the dog. But a very common complication is fracturing root tips. I'm not sure, I wasn't sure if this is a complication or not. I don't really think so, but you may think of it as a complication. This is just a normal part of extracting teeth, because at some point you will have teeth with ankylosis, tooth resorption, or you just don't have instruments that are sharp enough, thin enough, and so you fracture them, and that's okay. But we need to know how to get them out. And if it happens, you fracture a root, the best thing to do is immediately you stand up, you say your very best swear words in your own language, you take some deep breaths, walk around, because usually you are very tense and tight and you are angry that it happened. Then just calm down, sit down again, make sure you have good light, good positioning, place the animal a little bit better, then make a flap, lift the flap, and remove more alveolar bone. I'll show you a case here where I fractured a root. So see here, okay, I felt now maybe it's a little bit too loose than it should be. And you see, yeah, it's fractured. So at this point, don't panic. Just know that you have to make a better exposure. And how do you do that typically? I say the easiest and fastest way is to do one vertical releasing incision. So you make like an L flap. You lift this flap up and you start to remove bone on the buccal aspect because you don't want to be digging into a bleeding hole from above and down, because that's when you do that, that's when you push roots into the nasal cavity or in the mandibular canal. So you always want to create space around the root tip so you can move it laterally. That's the most important thing about root tips. Don't try to force your instrument down next to the root tip to twist it and get it out. Create the space with your burr and then insert your elevator and move it sideways. So now I enlarged the flap a little bit here, and I took some pictures of some burrs here on the right side. The long one is called a root tip burr. This is the one I have right here. It's very long and very thin, and it's very useful for root tips. So see what I do? I simply I remove some of the buccal bone until I see the root tip. But what about if you don't see the root tip? I think if you have then good dental loops with good magnification and lights, you should be able to see it. But if you don't have that, it can be very difficult. So it's really something I encourage you to get. So this is what I mean by create some space around the root. See, I made a groove on one side, and this is where I can now insert my elevator or luxator here, and I can start to move the root sideways. I remove the bone on the buccal aspect. I could get in here and move it out. You know what I mean? So don't try to push it or force it. Make some space around it and move it sideways. So that's but we could talk for hours about all different cases about how to get out root tips in different positions in the mouth. Maybe that's for the next lesson. But for now, this is what I wanted to show you, the concept of it. And what you see here is a root tip pick. And it's basically, it's very useful to, it's very sharp. You see the edge here, it has some spikes. So you insert it into an alveolus and you can use it to tease the root tip out, so move it sideways. And so this is a very nice instrument. I'll just put in the chat the name. It's called root. Root tip pick. If you search for that, you can get them from Accessia, you know. If you search for that, this is the one that you will find. Accessia is where you can get most of the equipment. Okay. So, and again, if you get any questions for the things I talked, just put them in the chat as we go, and I will go through them at the end of this presentation. So dehiscence happens sometimes. You make the perfect flap, you make everything right, and the patient goes home, something happens. It can be a little bit of what do you call it, hypoxemia. So it could be a blood supply to the edges of the flap may not be perfect. It could be that the dog or cat got into it or scratched the face or ate something that was too hard or grabbed some toys, or sometimes it's not always your fault. And I would just say it's going to happen. And I'm more relaxed now when it happened than I was when I took these pictures. And you will see that I'm trying to repair this. If this was today, I would just tell this owner, go home, take some chlorhexidine gel, whatever you keep, come back in 3 weeks and we'll recheck it again. Because most things they do heal. And if they do heal by themselves, cats are fantastic healers. I mean, this wound is not a big issue. They don't get infection. They don't get like a huge problem. So, but if you were to treat this, you would need a flap that is at least, you have to redo the surgery, right? And you need a flap that is a lot wider than this defect. So you see, this is what I did in this case. You made, the defect was here, so I made the flap very big so I can go in and smooth everything down and trim the edges and get more space. Here are some nerves and vessels coming out of the foramen. So when you extract the lower canine, at some point you may meet this guy here, which is the middle mental foramen. But you can remove bone down to this point here without any problems. But you see how large flap you actually, if you are to successfully close, open everything up, release the tension and close again, you need to make a very big flap. A small tip I want to share is that if you want to secure your flap a little bit better, so the tension is not on the suture line but on the flap itself, you can use a drill, you can make a small hole in a bone, you can put your suture through and then feed the suture here into on the inside of the flap, take some of the soft tissue here and then pull it back towards this spot. So that means you are making like almost like a tag, like those walking sutures where you do subcutaneous sutures, where you keep the tension off of the suture line. We don't want tension up here, but we can pull the flap in by grabbing that bite. So that's just a small tip you can use. And then after I did all this, this is what the closure looked like. So you see now you have a fairly big lesion that needs to heal again. So it's okay. And if it doesn't open up, then this will heal normally, like within 5 or 7 days. But just remember, if you see something like this, you could just say, let's wait 3 weeks, come back. And it's like most of the time it has healed very well. This is another case. And I was a little bit afraid of what is the bone is like. Do we have a little bit of osteomyelitis or do we have problems here? So I decided to open this up again. And you see again, you need to make a very big flap and you need to release the inside of the flap. See here, the way you check if a flap is tension free or not, you have to be able to place the flap over the defect, and when you let go, it should stay there. It should not pull back. So this did not have tension. You see, I let it go and it stays there. So that's good. But if it doesn't, you have to go in like from this part here and do blunt dissection, release the periosteum, and to make all this flap more loose. Again, that's a whole different lesson on how to make all these releases to close the flap tension free. I just wanted to show you the extent of it, and this is the closure again. If it was today and I saw this, I would give it 3 more weeks and let it heal by itself, because this is also a big surgery, right? You're making new damage and new swelling and new pain and all of this stuff. So it's just so you know, you don't always have to panic or try to fix it, or because usually things will heal by themselves. There is a small, I see a lot of, not a lot, but you know, the breeds where I see most dehiscence of the lower lip are brachycephalics. So it could be boxers, it could be pugs or bulldogs, or Staffordshire bull terriers. They have a very like heavy lip, and it's pulling on the sutures. Especially this right here. This is called it doesn't have a real name, but it's called we usually call it a frenulum. So the mandibular frenulum here. And when the weight of the lip pulls down, it will pull on this point. And if you make your flap across here, then by pulling the lip and the frenulum, you will be pulling on the lip, on the suture also. But if you do your incision down here in front of the frenulum, then I'll show you in this video to make your incision here. Then when you pull on the lip, see, it doesn't pull on the suture side because you still have this intact frenulum. Yeah, so that could be one technique. A good idea if you have those large breed dogs or brachycephalics would be to do maybe a horizontal mattress suture here. So grab a good bite on the inside, pull it through here on the lingual, through the gingiva, out, in again, and then tie a knot, and then repeat one more time here. So you close almost in 2 layers. That's always a good idea with the mandibular extraction sites, that you do like a horizontal mattress suture underneath the primary closure to pull the flap in. And when you suture here, there will be no tension on the suture line. So that's a tip that you can use. This is a case of oronasal fistula. And sometimes we see that if you extract an upper canine tooth and it opens up again, it will create a hole between the oral cavity and the nasal cavity. And that's an oronasal fistula. And those will not heal by themselves. You will have a permanent opening, which is a problem because you can get food and inflammation in the nasal cavity. This hole had been tried to fix one time before I saw this dog. So there was already one surgery to try and fix it, and it didn't work. And then I had to come in and do an attempt to close it. I think what happened when they tried to close it the first or the second time was they simply made the flap way too small. So in this case, you have to make a flap that is maybe 2 or 3 times the width of the fistula. So you see here, this is the incision you make. So you have to be quite comfortable with working with flaps if you are experiencing oral nasal fistulas. If not, it's a good idea to refer. And who do you have? Do you have someone in your area to refer to? You know Magnus Anderson? Is he? What's his name? You can just unmute and speak up. Is there some who's a specialist in?
Yeah, Magnus Andersson. He's
Yeah.
nearby Örebro, I think.
Okay.
But we also have a few
Yeah.
other specialists. Yeah.
Yeah, because some people like him will be able to do this, but just so you know, you will have to do quite a big flap, and then sometimes it's better to refer. And the most important thing is that you trim the edges very well, because when there's a fistula, the epithelium has grown into the lesion. That means if you just try to put it together with the suture, it will open up again. So you have to debride the edge. And a very practical way of debriding the edge is using a diamond burr. So a round football diamond burr, you can touch the gums and the gingiva with your burr, and you can run it along the inside, and you can remove granulation tissue and epithelium and everything with the burr. It will not destroy the flap, it will just smooth the surface and debride the surface. If you try to do it with a Fisher burr, the long straight burrs, or a round burr, you will not do so good. It will destroy soft tissue, and so we want to use a diamond burr. And if you don't have enough, if you have too much tension, where should you release this flap? Well, you should insert your scissor up here to try and release on this edge, and do blunt dissection, and do, this is the mucosa, and beneath this you can get in between those layers and you can separate them to close with this edge here. Here are some of the vascular nerve bundle coming out. So, but you can stay superficial to that when you release it. And you want absolutely no tension. So again, how do you check? Well, you put the flap over the defect, and if the flap does not pull back, then you don't have tension. Here is I took the flap, I put it over the defect, and I could easily pull it even more. I could pull it way over. And that's good because all this inflamed tissue, I wanted to cut this off. This is not good to close with this. You want to take your scissor and trim this off and then release the flap even more if you need more tension free. And this was what it looked like after. So sutures are all the way from here to here. And remember the hole, how big it was? Seems quite small, but you need a quite long incision. So, and this dog had it bilaterally, so I had to do it on the other side also. But it healed well. It healed perfectly with a nice big flap. Okay, what else can happen? We can have jaw fractures, and one of the big reasons why you probably heard with cats. I heard some stories about training sessions where they are extracting lower canines in cats, and most of the participants they broke the jaw trying to extract those canines, and it was a big mess. Usually, when that happens, it's because you didn't make the flap large enough, you didn't remove enough bone, or you didn't take an X-ray before you start to extract. Because if you don't take an X-ray, you may miss a tooth looking like this. This is a tooth that has tooth absorption. And if you try to extract this, you will fail because this is not going to get out. This is already resorbed, and you will put your luxator elevator in here and you will twist and then the jaw will break. So always make sure that you take pre-op x-rays. I always recommend take full mouth x-ray of every single patient so you don't miss disease. And go to a wet lab or learn how to make a proper large flap and how to comfortably remove more bone. That's how you avoid it. Some small breed dogs, they have so much periodontitis that they can break the jaw just by nothing, just by eating, and usually it's because this big molar is very common to get a very much periodontitis and bone loss, and the root tip is very close to the edge here. So at some point, this jaw will get so weakened that it will fracture. If it happens, then you have to get out the teeth that are in the fracture line for it to heal. And you could do either just a muscle, you could try to pull it together with, if there are teeth, yes, you could do some interdental wiring, put some wires and a composite, and that's obviously not a procedure that most vets have learned. But sometimes just suturing with PDS and putting on a muscle, that can also help with the healing once you get the bad tooth out. And some of these dogs, they never heal. They develop a non-union, so they develop like a fibrous tissue connection. And that's just the way it is. But if it happens, if you break the jaw during surgery, then it's a great idea, to refer, put a muscle on, get pain medication, refer to someone who can evaluate and see if you can do something to repair it. But it's something that happens sometimes, and usually it's because the dog come and see you 5 years too late. That should have been a long time ago, and you are dealing with a very thin bone. So how to fix jaw fractures? That's again as not the aim of this lesson, but there are different ways to do that. What if you push a root in the mandibular canal or nasal cavity? Roots looking like this with ankylosing closes, you see this is a normal root. You have a nice black line. This is the periodontal ligament, and you should need to be able to see periodontal ligament around each root. So these are normal roots. There is a little bit of bone loss here, but when you look at this root, you see the line is gone. That means they are ankylosing, and they are also probably partly resorbing. So these roots will be very difficult to get out unless you make a flap and remove bone and move it sideways, as I spoke to you before. But sometimes you struggle and you put a little bit too much pressure on it, and then the root goes into the canal. And yeah, this was this case. This was what happened with this exact dog. So we got out this tooth, and you see this root here, maybe it's inside the canal, but remember this is a 2D photo of a 3D structure. So the root can be behind, like lateral or lingual to the canal, or it can be inside the canal. You never really know unless you do a CT scan. In small breed dogs, the the mandibular canal is often on the outside, so on the buccal, and that is a problem because we want to drill bone away here. But now, before we reach the root tip, you may drill into the canal. So, with very small breed, 85% of the canals are on the outside, the buccal aspect. So remember that. Don't drill too deep in small breed dogs. In large breed dogs, you can drill all the way to the root tip and you will not enter the canal because it's below. But in this case, you see the root tip was pushed down. Sometimes you will push it down and in like this. If that happens, you have to go in from above and get it out. And see, this is the extraction site. Not very easy to see what's going on and to find your root. So if this happens to you, you have to be very, honest to yourself and say, do I have loops and lights? Do I have suction? Do I have experience with root tips? If not, it's better just to close and send to someone who can get it out. But I will show you the concepts of how you get it out. So basically, you want to open up to create a better visibility. So you make the flap here, you release just the lingual and buccal side, make an envelope flap, try to get some of the blood away. And here I could see the root here. I could just see the top of it. Sometimes you don't see it. But the concept is that you want to create a window. So you want to use a diamond burr, not a straight burr, not a round burr, because you will damage the soft tissue or the vessel a lot more if you hit it. So use a diamond burr. It could be a long diamond burr, or it could be a football burr. But use like this to create a window. So remove more bone here. Sometimes you have to remove all this bone that goes, let's say the root tip moved this way and it's now underneath here. You can create a window. So just remove this bone here, here, here. Take small steps at a time, 1 millimeter, check with an x-ray, how deep am I, and remove window. Sometimes you will see examples of you move in from the outside through the skin. I would say this is not, it's more, I haven't done it myself. I don't see, if you go in from the lateral, I would at least go in intraorally. So take the lip away and go through the gingiva, not through the skin. That's a little bit too difficult. But this is what you see. This is a cadaver. So when you open up this window, now you have right here the mandibular canal, and the root may be somewhere in this area. And
yes, in a couple of minutes.
that's how you can get them out. Somebody in that mute.
For this trade.
Can we just
That's 17B.
okay, I found you. Muted you. So you see, it may seem a little bit scary because you may hit the nerve and vessel, and yes, that's a possibility. That's why I suggest that you only do this if you have suction with a small suction tip and you have good loops and lights and so on, because you are dealing with very delicate area. But it is possible also for the general practitioner who are doing a lot of dentistry. You can absolutely do this if you are just careful and you have some good equipment and lights and burrs and so on. The problem with leaving a root tip in the canal is that it will most likely create some inflammation around the root tip. And if you have inflammation near the nerve, you can get chronic nerve pain or some sensation that doesn't feel pleasant. And we cannot ask the patient if they are in pain or not. So that's why we assume that it's going to be an issue, and we like to get them out. So you don't have to do it the same day. You can wait maybe 1 week, or it's not an emergency, so you don't have to panic and send it the same day to emergency hospital. You can wait a couple of days. They can go back in and fix it. So yeah. Luckily, it doesn't happen too often if you follow the rules of never push on a root tip, but move it sideways. If you go in the nasal cavity, it's getting a little bit more tricky, because now you may need a CT scan to see where it is, and so I haven't pushed one in the nasal cavity yet, but it's more difficult to get them out for sure, and you may cause some chronic, nasal discharge and some problems in there. And if you push the palatal root of 108, 208 up, it doesn't go into the nasal cavity. It goes into something called the maxillary recess, which is part of like the sinus system. And that's really, I've never seen anyone get a root tip out from this area. So try to avoid it if you can. If you can see the root tip, but you are sure that if you just push it a little bit more, you will lose it, you can buy some files. These are endodontic files, and they are called Hedström files. I put it in the chat. So Hedström files is a endodontic, and I would get like between 40 and 80, the size 40 and 80. Even though if you're not doing root canal therapy, you can buy the short Hedström files, size 40 to 80. Just keep a package in your cabinet. So if you have a root tip that is tricky, sometimes you have a root tip, you can move it very easily from side to side, but you cannot get it out. You cannot get a good grip. You can take a file and you can screw it into the nerve canal of that root, and now I can pull it out. I've been able to do this a couple of times. Also on the third incisor down here, I had a root tip I was afraid that I couldn't really get a hold of. Using a file is good, but also just, even if you cannot pull it out with the file, just by screwing it in the root tip, you are securing it. You are making sure you're not losing it. And then you can work around with your luxator, elevator, your burrs, but you still have a grip on that root so you will not lose it. It doesn't work for all root tips because sometimes the canal is not so wide. So it has to be a canal where you can kind of see the opening, that it's wide enough to get one of those files in. So I recommend to buy one of those sets. You can get them at Accessia also. What about nerve blocks? Complications. I recommend to use bupivacaine. Lidocaine is only working 1 to 2 hours, not even the whole procedure. And when they wake up, they're in pain. Lidocaine mixed with bupivacaine is also something you hear a lot. It doesn't have a good effect. It has a worse effect than using them separately. People will say, oh, you will have a faster onset of action and a longer duration. It combines the fast onset action of lidocaine with the long duration of bupivacaine, but that's not true. they are canceling out each other. The pH values are different, and it means that you will actually get a slower onset of time and a shorter duration, and there's no reason to do it at all. So just use bupivacaine. That's my recommendation. It usually, but then you say, oh, but it takes 20 minutes to start working, and I don't have 20 minutes. But in reality, it starts working after 5 minutes. So in what it say in the book is not what happens in the mouth. It works much faster. So typically around 5 minutes before it starts to work, and it will last typically 4 to 6 hours, up to 24 hours for this. So I like to use that for all my extractions, but you always have to aspirate before you inject, because you can get systemic toxicity, you can get some cardiac problems if you inject bupivacaine intravenously. But I've never seen it happen. I used it for 13 years now and never seen any cardiac issues. But just make sure that you aspirate. Anesthesia of the tongue, that is something you hear more about than you should actually be worried. Because once you learn how to place nerve blocks correctly in the exact spot where you need to put it, and I also have, teach a course about this. But once you learn how to the exact spot where to put it, it's extremely rare that you have any complication. I will say, however, that like a month ago, I had my very first anesthetized tongue in a dog. But that's 13 years of doing it in every patient, and I can explain why I think it happened. So I'm not too worried about using it. Don't use near neoplasia. Inject local blocks into tumor, not a good idea, because you will seed some cells. It doesn't work to put local blocks directly on the inflamed tissue. Like if you inject it around the tooth that has periodontitis, it doesn't usually work because the tissue is inflamed, the pH is different, and it doesn't. It will neutralize it. Don't use it with adrenaline. It doesn't make any sense. The reason why you put adrenaline in local blocks is when you do like infiltrations of the skin, you want the vessels to constrict, so you keep the block in this area of skin, but we don't need that or want that near a nerve, because we are injecting it very close to the nerve, and there are no vessels that we need to constrict and so on. So this was my case about 1 month ago. It was Staffordshire bull terrier. When it woke up, I saw that it was moving the tongue very strangely, and it was starting to bite on it. So I was getting very surprised because I never had it happen before. So what we did is we immediately gave it some sedation again, and I called the owner. I said, we may need to keep this dog sedated for 4 to 6 hours or max up to 24 hours. But really, in reality, you can wake them up and just put a muzzle on it, because the muzzle will prevent it from opening up wide and catching the tongue and chewing down again. So that's when it happens, when it's able to open the mouth and chew. Obviously, how to avoid this? The reason it happened, I think this was a jaw fracture case, and you put the local block on the inside here on the mandible, a certain distance in. And while I was injecting it, I thought, is this maybe a good idea? Because on the CT scan, you could see the fracture went straight through where the nerve is. So I think what happened is that there was so much inflammation and things going on inside this area where the nerve is, that it moved out and anesthetized the lingual nerve. So this was a very abnormal situation. I think that's why it happened. And I should have just not used it or used lidocaine instead. But I'm not afraid to do it again ever, because I know this was a very special situation. And after about 4 hours, it was normal. the tongue was working normal, and we sent the dog home. So it was lucky. It didn't bite anything. But if you want to avoid it, let's say the tongue is a little bit anesthetized, which is very rare. Just make sure that your dog, when it wakes up in sternal recumbency, not lateral with the tongue hanging out. You want to put it on the chest and make sure that tongue is inside when it's waking up. Cats is not a big problem because the tongue is not very long and it usually stays in the middle. So, all right. Sometimes after extractions in general, you'll have dogs that will do this. They start to lick, chew, bite. And when I see this, I always get a little bit sad because usually I've had about 3 or 4 cases like this in my career, and they never go back to normal. Some of them we had to euthanize because they were in panic, and they kept licking and licking, and some of them are like running around and running into things because it was bothering them. I think it's some sort of nerve reaction, maybe pain, not pain, but it could also be maybe there's tingling sensation or some sensation in the mouth or the nerves that makes it do this. You can try to combine like NSAID with gabapentin or pregabalin to for nerve pain protocol, and do it for a long time, like weeks or months, and let the owners know if this happens. It may never go away. You may get lucky that it does, but yeah, it's usually not a very great sign when I see this. And I went back, and it was me who extracted it. Everything went smooth. It went perfect. I extracted some molars in the lower jaw, and I could see on the X-ray that there was like a lucency around one of the root tips. So I think there may have been a little bit inflammation around this root tip, and that was close to the nerve perhaps. And when I took the tooth out, maybe it pulled a little bit on the nerve. And so it's just something you cannot really avoid. But when it happens, try gabapentin or pregabalin with NSAIDs for a while, and then hope that it'll go away. Sometimes when you wake them up after anesthesia, you see tongue swelling like this. You also see sometimes sublingual swelling. In dogs also, here, some swelling in this area. There may be a few reasons. One reason could be that you pack the pharynx too hard. So you can use a pharyngeal pack, which is maybe some sponges or gauze that you tie together and you put in the throat to keep water from entering the back end of the throat. But if you pack it too tightly, they may block some of the lymphatic drainage from the tongue, and you'll get this swelling. Almost in every single case, it will go away after some hours. So don't worry too much. Also, this cat tongue also went down, but sometimes they react. We don't know why. You could give some steroids intravenously if it's like a brachycephalic breed and you really don't want some extra swelling, but usually it will calm down. It could be packing the throat or the pharynx too hard. It could also be if you have been using your high-speed drills too much, or been using your 3 water air syringe, the one. Because if you push air into the tissue too much, you will get swelling. I even had a dog that had swelling on the top of under the skin with air, because we had a root tip in the maxilla and we were using the air water syringe a little bit too much, we found out. So it introduced air into like an opening in the bone and under the skin. Not a good situation. So try to avoid and spray too much air into the tissue. Okay, let's see. Yeah, I talked about tracheal tinnitus. I'll get the music. So what I wanted to show you is that when you turn a patient, especially a cat, always detach the system here. Hopefully all of you do it, but not everyone does it. And it's just a reminder, because if you twist the tube inside the trachea of the cat, you can get a tracheal tear. And I've seen that when I worked emergency. I've seen that maybe a couple of times a year, where a cat came in with dyspnea, and it had like emphysema in the neck area and everything, and it can be a tracheal tear. Most of them survive; it will heal, but some of them, they do pass away due to this. But just be careful. It does happen, and it happens mostly in dentistry because we're moving the patient so much. So just a reminder to do that, to avoid pulling too much on the tube.
Huh?
I recommend
What is
to
his
have
name?
ties. This is the fluid lines from the intravenous fluid, and we take them from surgery, and every time we're done with a fluid line, we, instead of just throwing it out, we cut it into 3 pieces, and we use it for tying the tubes around the ears. And it's very effective, because when you tie it, it will grab onto the silicone tube, and it will make a very good connection here. So that's a tip. Ultrasonic scalar complications. If you use it on a too high setting, the ultrasonic scalar, you may do scratches here in the enamel. And some dogs are more prone to it than others. Some have like weak enamel, and some have very hard enamel. But just make sure that you don't turn it up higher than necessary. Especially in cats, try to turn the power down so you avoid getting these scratches. If it's just in the enamel, it's not an issue. You can just polish it away, or you could put a layer of bonding material on top of the tooth and polish again afterwards, because else the surface can be a little bit sticky or plaque and so on. So you want to polish again. Okay. Also, with the ultrasonic scaler, make sure that you check when you're scaling the tooth that you're keeping the lip away. Because if you don't do that, you will get like this. What happened to me, you get some burns. This is a burn mark because you were not paying attention, and the ultrasonic scaler were touching the lip. So make sure that you check that. In cats, some of them can go blind after. Have you ever tried that? That sometimes after anesthesia or dental clean, the cat suddenly cannot see anymore. And the reason for that is that you may have used a mouth gag that with springs, or it was opening too wide. So I don't recommend using mouth gags when you are doing dentistry. Try to, if you have to use it, absolutely, only for a very short time. And it's better to use a syringe or a tube. You can cut, if you throw them out, tubes. Instead, you should cut pieces of the tubes and use them as mouth gags. So the difference here is that it's not actively opening the mouth all the time. It's just keeping it open. Like a spring would actively try to open even more. And if the cat opens too wide, the arteries going to the retina of the eye, they will get crushed, and the retina will lose its blood supply, and then they may get temporarily or permanently blind after a procedure. So that's why we don't want to use these mouth gags. Let's see, something that can happen with a flap. I don't have too many slides left, so it's soon ready for Q&A. So if you have any questions, put them in the chat, please, and I will look at it. See, especially in cats, the flaps are very thin, and it's easy to penetrate. So sometimes you may make a hole in the flap. This hole was not made, but you see it's like it was a fistula coming out from this tooth. And I decided to leave it, and fortunately it did heal. It healed, but it's a little bit risky because this area has not very good blood supply. But if it happens and you make a hole, you make the hole through the flap, my advice is just put a suture, try to suture it together. It will usually heal quite nicely. I want to share also, remember, if you're doing something that is a little bit more exotic, then always get follow-ups. This was a case that of a jaw fracture, and I decided to try a little bit different method of fixating it. There's something called a dynamic mandibular maxillary fixation. It just means that you are aligning the jaw and you're allowing the cat to open and close a little bit to keep some movement in the joint to avoid the ankylosis of the joint and so on while it heals. But the problem is that this cat came in like right before my vacation, and I trusted that, 1 week should be okay before I saw this cat again. But unfortunately, this lack of follow-up led to this is what it looks like when it came back and I saw it. And I was not very happy with the result because what you can see is the elastic band they broke, and that means the jaw got out of alignment and it healed in a bad position. And you see, I also don't like, this is a case from a couple of years, maybe 5 years ago. I also don't like to put this wire anymore. There's a better technique where you, if you have a symphysial separation, that you put a wire around here, the tooth, and put some plastic composite in between here. It's a little bit better than this wire, but if that's what you have, the wire in clinic, it's better than nothing, and it will align the jaws. So what did I do? I could not fix the jaw, so you have to fix the secondary problems. You see this canine tooth here now is making a hole in the palate, and so I decided to extract these teeth, and this is what it looked like. So the result was acceptable. It lost some teeth, but it can live a good, perfect life without those teeth, and it can eat normally, and it doesn't matter too much more that the jaw is a little bit crooked. The cat was fine and is doing fine. But it was just a reminder that I wanted, is one of my, the cases you remember and you are not proud of, but it's just a reminder to always make sure that you do some follow-ups and don't trust the owner. I mean, don't say, oh, you can check yourself if it looks good. No, you can't. They can't. I mean, don't trust owners for anything. So, or at least have them take pictures, like open the mouth, lift the lips, take some pictures, and send to you if you are not in a clinic. So that's my advice for that. So yeah, 59 minutes, and so I hope that you got a nice little overview of some of the complications we do see in dentistry and how to avoid them. Did you record this session? No, I did. So I can send you the link, and if you want to share with your members, that would be fine with me. Just in case you had to do something else, and if you could not join the live session, then I'll share that link with you, and you can just send it. So if anyone wants to go back and see something again, you can. All right, let's look at the questions. So I'm in the chat now. Let's see. Okay, so Olga says she wanted to be mentally prepared for as many complications, even though not all can be prevented exactly. So they just, as I said, complications do happen, and sometimes we feel like it's our fault, and we should apologize to the owner. We should give discounts, but it's not the case, because we do a job. Sometimes it works, sometimes it's not our fault, and complications do happen. It's just the way it is. And with palate surgery, almost 50% needs another surgery, and you call it a revision surgery because you expect to open up and you need to fix it again. So instead of saying redoing it or doing it again, or just say we need some revision to make it heal better. Okay, Olga said, stupid question, what do you mean by flare? If you still remember, Olga, what I said and what you thought of when it was, you can put it in the chat. I forgot when I talked about anything with flare. In what cases or conditions do you choose to give up and leave the root tip to try not to cause a complication? Let's say there's severe ankylosis. That's a very good question, because yes, ideally you should get out all root tips, but not by risking the life of the patient or like making a huge damage. So I would say that if I can clearly see the periodontal ligament space around the root tip, I will go through quite some time to try and get it out, gentle with needles or drilling around it, and because I know that there's about a 50% risk that it will cause some inflammation. About 50% of root tips are inflamed, even though you cannot see it in the gingiva or on the X-ray. But if you have a tooth root that is ankylosing, resorbing, and it's very close to a danger zone, like a mandibular canal or infraorbital canal, I will give it a try. But if I feel like I'm really risking to drill into an artery, I would say it's better to inform the owner that it was too risky and just leave it. I don't recommend to drill out the root, if you know what I mean. Just take your burr and just try to, because either you drill too deep and you drill into something you're not supposed to, or you drill too little and you don't take enough. So it's very rare that you remove exactly the root what's left. I'm talking about intact roots. If you have resorbing roots with type 2 tooth resorption, where the root is getting replaced by bone, yes, you are allowed to leave them, but that's also, you have to make that differentiation between type 1 and type 2. I do have a recent video on my Instagram that talks about type 1 and 2. If you scroll down just maybe 1 week, you will see a video about type 1 and type 2, so you can see what I mean. Okay. Mia said, if you get a complication, a root in the mandibular canal, do you charge the owner to fix it? If it's, so if it gets referred to me, I would charge. If it was me who did it, I would probably be nice with the price. I wouldn't go, full, like double the price, or I usually, I would usually give them a good price, but you still charge for your time and the extra anesthesia and so on. But maybe it's not the time where you want to really charge a lot. I would say maybe. So it's just the way. It's up to you what you want. You can do what you want. If a patient swallows a mouth pack, oh yeah, I tried that, and it doesn't vomit when inducing, to send it for gastroscopy or to pick it up, or you hope it will pass. If it's a big Labrador and it's like a single sponge or something, you inform the owner and ask them what they want. Do you want to be sure and get them out, or do you want to try and pass? I would say you could. I would be scared to wait. I would be afraid of foreign body. I mean, it will get stuck in the intestines. I did have a dog once that did swallow it. That was before I started to tie like a string around it because I always thought, oh, I will remember to remove it. It's not a problem. But some days you forget to remove it because something else is happening, and then it swallowed it, and I have to take it outside and give it apomorphine, and luckily it got out.
Ajokurttia ja niitä vaikka
If
sieltä
they
pakastaa
swallow it,
sitä marjoja,
I
jos
would
haluaa.
I would recommend to have a gastroscope to remove it, unless the owner wants to try, if it's a large breed dog. Hannah, if you have a kind of granuloma on the vessels and a nerve in the mandibular canal due to chronic inflammation following periodontitis, what do you do? Have you seen that before? Hannah, how can you see if there's a granuloma on the vessel and nerve? Have you seen it on some sort of scan, or are you just saying that if we think there's a granuloma? What I will do if I have a big lucency, if I see a lucency or very severe periodontitis and I see that the root is extending into the canal, I don't want to scrape too much down there because, you know, if there's a lot of periodontitis, like the small breed dog I showed you an x-ray of, if I take out the tooth and I do what we are told to remove granulation tissue, and I take my spoon down there or my periodontal periosteal elevator and scrape it out, I'm pretty sure I will catch the nerve and vessel and I'll do much more damage. So for the very small breed dogs, I would just take out what I can see with my forceps of the granulation tissue. I won't go completely deep because I know I'm gonna damage something. So that's a good question. Olga said you mentioned flare when talking about complications around orbita. Oh, I think it was a symptom of penetration, but didn't understand completely. Flare is, you know, when you in the anterior chamber of the eye have particles. I think it's called flare, isn't it? When you shine a very bright light from the side, you will see the particles flowing around like protein particles or something. I'm not an ophthalmologist, but you will see things flowing around in the chamber and the fluid that will catch light, and that's called a flare. So that's what I mean. Yeah, good question. You suggested PDS when suturing soft tissue in case of jaw fracture, but I assume you would use monocryl otherwise. What are your favorite types of needles? FS2, P3. Yes, I use monocryl. To suture, you just use monocryl. That's the best. You can, if you run out of monocryl, you can use vicryl. It's not as perfect because it's a polyfilament, and preferably we like to use a monofilament in the mouth. There's also something called vicryl rapid. You can use that. It should be okay, but I prefer monocryl just because it's monofilament and it doesn't hold bacteria as much and so on. Favorite needle, I use a P3 needle, and I use a purple colored suture. Very important. You can get purple color because now you can see the suture and it's not translucent. Okay, last question. So if you have a big sponge, like in Sweden it's 10 by 20 centimeter and unfolded, it will have a tail staying outside the mouth and you don't forget it as easily. Okay, that's a very good tip. If you have, I don't know these sponges, but I think I've seen a picture that there's a tail. So if you do that, some veterinarians use hygienic tampons. You know, you can also buy them, or and use those for they soak up a lot of, and they have a built-in string. So that's also, I don't know how much they cost compared to sponges and so on, but that's also an option to do that. Sana said, what do you think about bath after dental surgery? Is there a bigger risk for infection, complication? What do you advise the owners when they strictly feed the dogs with BAF? That's a good question. I just tell them chop it up really nicely so it gets very fine particles, and don't give bones or antlers or anything. And if they feed BAF, they probably don't want to listen to you. They still want to feed bones. They still want to make some fractures for you so you can fix those. But just tell them to chop it. Yeah, chop it very nicely. Most of them, the owners I spoke to, they already have another, like a solution with some pate, or there are different types of bath. Some of them don't contain a lot of hard materials. Elise said, do you recommend to do re-X-ray when leaving root tips? Yes. So if you had to leave a root tip behind, I would tell the owner, I strongly suggest we have it come back for a new cleaning procedure. It's probably going to need it anyway in 6 months, and as part of that you do a full mouth X-ray again. I always recommend to take, a rule of thumb is to, if you remove teeth due to periodontitis, they need to come in maximum 6 months. Ideally, they should come in 3 months, because you want to stay ahead. The calculus comes within 4 weeks. There's also already a lot of calculus, but no owner will come in 3 months, I think. So maybe if you say 3 months, they will be there in 6. If you say 6, they will be there in 12. So yeah. Helena said, do you recommend dry food or wet food after dental surgery? I recommend wet food after. So I say usually 7 days of wet food and 7 days with no toys. Yeah, if I made a flap, if I just remove a cup of teeth, just put one suture across, and I didn't make a big flap that can open, they can just eat dry food, or that's not a big problem. They swallow it, most of it anyway. But the general rule, soft food for about 7 to 10 days. Yeah. Oh, so I think that was the questions for now. And most of the people stayed until the end, so that's very good. Elise said, "Oh, do you always suture after extraction?" Yeah, mostly. I maybe suture a little bit more than most. So even for incisors, I like to just put a single suture just to keep the blood clot in and to keep the alveolus closed, or at least approximate it. Not always you're gonna get it completely closed. That's okay. Just to keep the blood clot in. And sometimes when they wake up, they start to bleed when the blood pressure goes up. And I think I prevent that by putting some sutures. An exception is if you extract like 109 or 209, you don't have to make a big flap. It's actually better just to put the suture across in a cruciate pattern, just to keep a blood clot in. There was a study that showed it was around 220 extraction sites from 109, 209, where they just took the tooth out, put a suture across the hole, and nothing more. 99.2% healed perfectly without any complication. So don't stress over this that you cannot close it. You can just leave it. And the problem with trying to close it is that you will make more damage in the area. You have the salivary duct and the salivary papilla, and all. You don't want to damage those. So that's actually that will save you some frustration. Just leave it open. Yeah. All right. I think that's all. And